Great, live here, so super. So we've got John McManus, Tracy Spicer, Dr. Mara Holton, and Dr. Gary Kirsh.
They wanted me here, no.
All right, fantastic. So we heard a little bit this morning about some of the enormity of a decade of health policy victories, but we're going to just go to some really late-breaking things that have happened in the last 24 hours. And we tried a new format this year. And so, Dr. Mara Holton, I'm going to ask you the first question. Can you give the membership an update on what's just happened in the new CMS ruling regarding the recent CPT coding changes that we can anticipate in the next couple of years?
So first off, thank you very much, Dr. Shore, for inviting me, Dr. Kirsh. It's been a real pleasure to be on the Health Policy Committee, and I have note cards because I'm new, and also because a lot's happened in the last 24 hours. So I don't know how many of you have been checking your email regularly, but Dr. Kapoor reached out to all of the membership about the rules that CMS has promulgated, both the outpatient payment schedule and the Medicare fee schedule. So we've had a bunch of really significant wins for LUGPA that have happened in the last 12 to 24 hours. The first is a dramatic reduction in the 340B hospital drug program. And I was here last year, so there was a lot of chatter about this. Probably most of you in the room are familiar. I won't bore you with the details. But this was a significant initiative to reduce the exemptions that allowed the hospitals to generate residual cash pools from the 340B program. And that has real implications for the amounts of monies available for hospitals to deploy for a variety of things, but significantly as it pertains to us for the acquisition of physician practices, independent physician practices. The second and probably most significant thing is a significant expansion of the site neutrality payment policy. And this is really a huge deal that attempts to level the playing field between independent practices and hospital physician-based practices. And really what this has done in addition is generate both an incentive for hospitals to acquire physician practices because there was residual cash there, and also residual cash with which to acquire physician practices. So this has tremendous implications, and it's really, I don't have a crystal ball, I don't know what's going to happen, but this may lead to some unwinding of some of those relationships that may create some market opportunities that are interesting for some of you in this room. LUGPA spoke on behalf of both of these initiatives, but significantly with site neutrality, we had a significant letter writing campaign that many of you hopefully were involved in, and I think Tracy can touch on that.
Yeah, I'll just start by saying thank you. It's great to be back, and really truly want to thank all of you that I know rose to the occasion when the head of our Health Policy Committee sent an email plea out several weeks ago to many of you and your practices asking you to weigh in on the Hill. So as you'll recall, the site neutral policy that Dr. Holton just described is something that was part of a piece of legislation 3 years ago. CMS has been working to promulgate those rules and then came out with a proposed rule about 2 months ago. What happened is in the sort of 11th hour, the hospital systems rose up and ran to the Hill, as they often do, and tried to unravel some of this policy. And we sent out a missive, and many of you responded. And thanks to the work that Dr. Kapoor and Dr. Kirsh do on a daily basis year-round, we have both the analytical and data capabilities to really drill down and get very granular with these letters. So many of you who sent these letters are very familiar. We're able to tell you how many offices you have in a certain district so that a member of Congress can actually understand better your footprint. You can make the case on behalf of your practice and your patients and what the impact and meaning is, both at the patient level and the physician level. And we were able to really halt some of the hospital's work in trying to unravel this policy. And so by stopping them in their tracks, before we knew about this exercise in the Senate, the hospitals managed to get half the Senate to sign on to a letter asking them to halt this policy. With a heads up in the House, we were able to keep that number to less than a quarter of the House. So again, we really want to make sure you are aware that your grassroots efforts make a difference. And I think in this case, having built the relationships that Dr. Kirsh is going to talk us through later, and all the work that we do all year long on the political side, building relationships with members and their staff, really come in handy in instances like these. And this is where health policy and the political affairs team work hand in hand.
Also in the OPS were some metric changes in the way ASCs are compensated, and I think John McManus.
Sure. So one of the things that we also made progress on, I know many of your practices own or are in partnership with ambulatory surgery centers, have been a priority for that sector for about a decade to get equal payment updates to the hospitals. They've been paid on a CPI index, which reflects inflation in the overall economy, which generally lags healthcare, and hospitals are getting what's called the hospital market basket, reflecting their input costs. So just this morning, after a lot of lobbying on that issue, CMS announced that for the first time, ASCs will be getting the hospital market basket payment update. That results in about a 1% increase over what would otherwise happen every year compounded out, and it stops the erosion of the ASC payments in relation to the hospitals. So when you look at the totality of the things that CMS is doing with our help and with our pressure, our grassroots pressure that Tracy mentioned, it's really moving us into much better parity with the hospitals. And I think it's going to be very important to keep our independent practices independent.
So fantastic. So that's a really big win for us, literally within the last 24 hours. And maybe I didn't hear it, but we were a little bit out on a limb during this. We had multiple calls with other organizations, and we basically showed a lot of data, and we were very in sync with CMS and their proposed legislation. And I think that was really important for us. Oh, thank you. That was very important for us to basically say, to take a forward-thinking leadership position. And do you want to comment on that at all, the fact that we did have a lot of conversation with other urology associations at the time?
Well, I think that's absolutely true, and I think really what you're speaking to there is the MPFS, or the Medicare fee schedule, where CMS really proposed the most significant change in documentation and E&M reimbursement in decades. And LUGPA spoke really largely alone in subspecialty groups in favor of this, and that was based on really a tremendous comprehensive analytical effort, which demonstrated that it was favorable from a revenue vantage point, but also favorable from a documentation and simplicity vantage point. And this was really one of those rare situations in which we truly could identify that we were aligned with CMS. And again, LUGPA really stood pretty bravely and quite alone in that regard. So I think Dr. Shore is right that was a tremendous initiative that integrated us with a number of other people, but largely by ourselves in tandem with CMS. And I do think it's worth mentioning that there's a change. Documentation requirements will change, and they will change significantly and simplify your chart management. And E&M codes will, for those of you who follow these things, be compressed. So level 1 and 5 will be preserved, but levels 2 through 4 will be compressed. But interestingly, urology was recognized as one of the specialties that has a cognitive element. So I guess they think some of us are smart, present company excluded. And there's a G modifier that enables you to expand the value of that code in our setting. So that was a big effort, and I think we were pretty unique in that. And then I think also importantly, LUGPA spoke in opposition to the multiple procedure payment reduction as it pertained to, they essentially they promulgated initial recommendations applying that to procedures done, reducing them by 50% on the same day as an E&M, and that did not come out in the final rule. And that's a big deal.
And Maura, I'm sorry, Gary, I just add that the consolidation of the E&M codes is going to be phased in and delayed until 2021. And I say that because to everyone's point, LUGPA did stand out in terms of their comments. The rest of the House of Medicine is not particularly thrilled with this result. So I think we should be fully expecting to be having to defend this position moving forward for the next several years. Rules are final until they promulgate a new rule. So assuming that the House of Medicine is going to continue to evaluate these codes and work with others in the industry. We're going to have to viciously protect the ground we've won. So.
Yeah, so it was essentially, you know, we were proud enough in our conviction of the data and what we were trying to do for our membership. And it was, as I said to Deepak before he left, it was a sort of mini Profiles in Courage. Maybe that's an excessive analogy, but I thought this was really a great win for us. Gary, you wanted to say something?
Very brief comment. I think it just as an overarching comment, what we've seen is a change of tone in CMS that has occurred as a result of the change in administration. And I don't say this in any political way, but the administration is on a charge to reduce regulation throughout many agencies, and we sort of seen that tone change in CMS. It's good in this case. It doesn't mean it will be good in the next case when we talk about Part B changes, but elections and change of administration make a difference in these things.
So let me just ask, well, I'm going to go with a question that's from here, and then we'll go to the Part B and then throw that answer over to John. But a question comes from the audience. Can you speak, and I think we've addressed it, but let's kind of finalize it. Can you speak further to the site neutrality rule? Will this finalize? Do you anticipate the independent rates will increase, or that hospital outpatient rates will simply decrease?
So what this does is it prevents the hospitals from starting new lines of businesses for acquired practices. So it's not giving us an increase necessarily, it's preventing them from getting extra windfalls. So it makes it less interesting for them to acquire new practices.
So that's great. So it makes us more competitive,
yes,
and levels the playing field. This is what we've always been looking for.
And there was a piece of the question, I think, that was asking if this is final. This is a final rule. So again, it's final until perhaps next year or the year after when they promulgate a new rule. So for now, this is a final rule.
Okay, super. So let me flip this one over to you, John, and I think this is important. So there's been a question recently in the press regarding the proposed Part B drug demonstration that would eliminate buy and bill and import international price controls. I mean, this just sort of was floated out there by the current administration. Thoughts about this?
So this is something Trump's been talking about for a while. The pharmaceutical industry is getting away with murder, and I think, as we'll talk about in a few minutes, if the Democrats take the House, I could see him working in Common Core with them to try to deal with drug pricing. Physician community is the proposal they put forward just about a week ago, 2 weeks before the election, no surprise, right? Would essentially subject half of the country to a demonstration program, mandatory for all doctors, where they would eliminate buy and bill. That would be replaced with a vendor-focused program through wholesalers or PBMs, and they would be utilizing prices based in Europe, including countries like Slovakia and Greece. So those prices would be applied to Medicare Part B drugs here in half of the country, and they would also influence the average sales price payment structures for the rest of the country. So we worked very closely, LUGPA did, with the rest of the physician community and hand-in-hand with many patient groups and manufacturers just a couple of years ago to beat back the Obama proposal. This is coming out of that same new agency that was established in the Affordable Care Act. It's called the Center for Medicare and Medicaid Innovation, and now the Trump administration is doing it. And it's basically disregarding all the statutory and regulations that are currently in the law and in the regulations that we work on from day to day, and allows them to do whatever they want with really no input from stakeholders. So I see a very substantial fight coming our way on this if we want to keep our current models, which we think are working to protect patient access. But it's a very popular proposal, as you might imagine, because what Trump is saying is, why should Europe pay less than America? And he wants to stop that freeloading. But the way he's doing it is to take physicians out of the equation in a very substantial way, which I think is ill-conceived.
And just to add a little politics, because tis the season, I will say that Democrats, interestingly, did not come out, many of them did not come out swinging in opposition to this. It was a somewhat muted response. So there were certainly some Democrats who, like when Obama proposed a similar demonstration, came out and said this could impact patient access, this could increase copays and out-of-pocket costs for patients. But for the most part, they were calmer and quieter because, quite frankly, drug pricing has, as you all know, has become a huge issue on the campaign trail on both sides of the aisle. And assuming the House of Representatives flips and becomes Democratic next week, I think you can be quite certain that Democrats will have a very robust drug pricing platform next year. And I think because they don't know what that platform entails exactly just yet, they don't want to get on the record as opposing things that they may try to actually usurp or hijack and revamp in their own way. So.
Okay, here's two more questions. So our ARS remotely here is working well. One, I think when do the change in documentation rules go into effect? I think that was answered. It's 2021.
For the E&M.
For the
E&M,
E&M.
for the documentation changes, my understanding is that the most straightforward portion of it is 19.
It's 19.
That's
okay.
correct.
Great.
And there'll be many missives coming to you summarizing all of that.
Yeah, by Monday you should all have an inbox filled
Dr.
with.
Kapoor will be.
But the payment changes don't occur till 21.
Right. The E&M compression, those changes do not occur till 21.
And then sort of another question on that was, please explain in more detail how the E&M compression is a financial win.
So, again, there's more to come, and I don't want to get into too great of detail because it'll take another 25 minutes to go into it.
We can cut into Dr. Kirsch's time. He won't mind.
Yeah, no, I
Never does.
He's always gracious about that. Essentially, it involves the addition of them. It does pertain to the addition of the G modifier for complexity, is kind of the long and short of that answer.
Okay, super. All right, let's go to some other topics. So let's talk about the Medicare Modernization Act and where we are and regarding Stark and self-referral law. What does that legislation do and how is it progressing in Congress? I think you're all going to want to weigh in on this. Let me start maybe perhaps with you, John.
Great. So I think last year when we were here, Congress had just introduced legislation on a bipartisan, bicameral basis to modernize the Stark law. And now, even a year later, we're the only bill out there doing that. There's a lot of other interest groups who are interested in doing this. They can't get consensus. They can't build the political support. We've now have 25 groups come onto the bill that we drafted and endorse that. And I think we have 24 sponsors in the House and 5 or 6 in the Senate. Most significantly, this summer, a key stepping stone to getting a law and getting a bill into law is to have hearings examining these issues. And lo and behold, they invited our own Dr. Kirsh, who testified at the Ways and Means Committee. Maybe, Gary, you can say a few things what it was like doing that.
It was great fun, and I only wish it could have lasted longer. The Stark Reform Bill has been our #1 legislative goal for the last year or two. It's unclear if it'll get through this year. In fact, I think it's unlikely, but it takes years. And one of the things that John or Tracy will always tell you is it's way easier to block legislation than pass legislation. So, but we're working on it. The purpose of this is somewhat arcane and could bore you and divert the conversation. Suffice it to say, it's not so much about the Stark law in terms of your current arrangements. It's about Stark law as it applies to APM development. And one of the reasons that we don't have enough APMs, as I said in my earlier presentation, being presented to the government is because of the prohibition on novel arrangements between entities. They can't work together and they can't test APMs. So this is what the legislation tries to address.
And Gary, I know I sound a bit like a broken record, but I will just say that on Gary's behalf, all of this political activity that Gary generates and that you all gratefully contribute to makes an incredibly big difference. Because what we have learned, and what I think many of you who have come to Washington and done these visits with us on the Hill, it takes 4, 5, 6 visits to the same office with the same member and the same staff to go over materials related to Stark. It is an incredibly dense and difficult topic. Many of the staff on the Hill were not around for original Stark laws and don't know much about them at all. It certainly isn't something that governs their day-to-day. So there has been this real learning curve that we have had, particularly on the Democratic side, to appease people and say, this is not meant to to alter Stark in a fee-for-service environment. To Gary's point, this is really directed at alternative payment models, and at least on our side of the aisle, we can make the point that it's very similar to the language that was afforded to ACOs under the ACA. And again, it's really been a multi-pronged process of having to go back to these offices. So again, we welcome all of you to come and join us in DC. We will put you all to good use.
But if I can make a comment on the substance of it, because it does go fundamentally to this earlier discussion on the site neutrality. There are probably 500 accountable care organizations. They're fundamentally hospital-led organizations. You also have about a third of Medicare beneficiaries and Medicare Advantage. Who's left out of that? Independent practices, okay? So we've seen that how ACOs have operated. They've generally pushed up costs. They haven't reduced costs, but they've used that power as a bargaining chip to threaten practices to say, if you don't join, you're going to be frozen out. And we know that the current APM approval process is totally dysfunctional. What this bill would allow is a testing of an APM before it's approved. It would allow the Secretary to provide the same waiver authority that the hospitals got through the ACOs to independent practices. And it repeals the volume and value prohibitions that are currently in the law with respect to APMs. Right now, you cannot share resources amongst a group or across groups from your what they call designated services, from things like your laboratories, from radiation therapy, from high-end imaging. Those resources can't be used to try to incentivize volume or value. Well, if we're trying to move to something called a value-based world, it's totally arcane to say, well, we can't pay for value. So Congress is now recognizing that. I feel very good about where we are. We've got Senator Portman, who is a very thoughtful member on the Finance Committee. He's probably one of the most senior members on the Finance Committee. He's championing the bill in the Senate. In the House, it's going to be, we got a good group of bipartisan members, but let's say it's not a priority for the Democratic committee staff to move this legislation. That's their challenge next year.
So I have to say it's really a testament to all the hard work that John and Tracy have been doing and the expertise of Howard Rubin. But I want to just ask Mara, you're relatively new to the Health Policy Committee. You've really weighed in on it enormously. I've gotten incredible feedback on the success that you brought to it, along with Mike Fabrizio and Aliku. Deepak couldn't be here today. Can you tell us a little bit about what the experience has been for you?
Yes, so my first exposure to the Health Policy Committee was actually on one of these fly-ins that Gary likes to advertise, and it was on this Stark legislation. And then subsequently, and it was really actually great and a very significant learning curve for me, and continues to be, thus my note cards. But we actually had the opportunity to meet with CMS. So again, this is what they're talking about, a statutory change, but there's also opportunities for regulatory change as it pertains to Stark. So this is, you know, sort of a buy effort and is incredibly important on both of those levels. And CMS asked for, they had a request for information this year. We submitted some comments. Those comments were actually so well received that CMS asked for an in-person meeting. So again, of all the stakeholders, I'm sure that they asked for some other in-person meetings, but we were certainly selected. And that was a great opportunity to meet with CMS. And actually at that meeting, they commented that our comments were the most helpful in guiding their understanding of really the pressing need for reform if APMs are going to be meaningful in this sort of brave new APM world. And that really goes directly to the quality of the work. The people who wrote this comment, Dr. Kapoor, our lobbying, our legal team, really queried all of you about specific examples, which is actually exactly what the CMS RFI asked for. And what they told us in that meeting is that we were actually the only stakeholders who provided those kinds of granular examples of models that could not go forward or that were inhibited because of the existing statutory regulations and legislative and regulatory regulations. So it was really a great experience.
So I really appreciate how you're describing it, you know, how the sausage is made. It gets made not only through the expertise of Tracy and John and the dedication of the Health Policy Committee, but the full board, the political affairs, the back and forth. And so just so that you know, the rewriting, the editing, the thought process, the calls that occur all on behalf of membership, I want to thank you all for doing that. Let me just, we've got a couple of more minutes before we turn over to political affairs, and we're definitely not going to deprive Gary of that opportunity. Let's talk about right now with the elections, and it's always kind of fun about LUGPA, our annual meeting, is we're right always before a pretty darn significant election. So it's just literally days away. Maybe I'd like to have, Tracy, maybe you can start, and John weigh in, our Democrat and Republican experts, on what would happen if the House flips to Democratic control, I guess the degree of the flip, and how do you see the healthcare landscape changing, and what should we be thinking about preparing for as LUGPA?
Thanks. Thank you. Look, I think we're feeling fairly confident that the House is going to flip. I don't think it's going to be some massive wave that people are talking about, blue waves. I think it will be a dozen or somewhere in around a dozen or 15 seats, enough to give us a gavel and some chairmanships. But I think the beauty of LUGPA is that we transcend politics. I think based on the work that the Political Affairs Committee led by Dr. Kirsh has done for all these years, we have been building relationships on both sides of the aisle in both chambers of the Capitol. So yes, it will be a different focus for Democrats. As John said, I think Stark becomes a little bit more of a hurdle because Democrats are less anxious to pursue that. I think there'll be a lot of focus on drug pricing, and our caucus is likely to kill one another talking about a Medicare for All bill that is never going to go anywhere, but we will kill each other trying. And so there'll be a lot of preoccupation. There'll be a tremendous amount of oversight into pretty much every healthcare industry and every other industry you could possibly imagine, because that's how Democrats will try to, rein in this administration. But all that being said, I think for LUGPA, we're going to continue to put our heads down and do our work. I think the one thing John and I are very on alert for is a good old issue that many of you remember us sitting up here talking about for years, which is the IOASE, the in-office ancillary services exception. It is what allows you all to do, your referring of imaging and radiation therapy and whatnot. That has always been a threat when Democrats are in control. It's unfortunately saves money if you were to repeal that exception, and therefore it can be used as an offset. I think we can all expect that will get thrown back on a table by our opponents and by Democrats, and we will once again, as we're doing all this other work, have to go back on defense, and we're certainly prepared to do that. But those are the types of things that I would anticipate some changes in.
Well, one thing that's also we should note is it's likely that the Republicans actually gain seats in the Senate, just because of how those seats come up. 1/3 of the Senate gets voted on every 2 years. So there's a lot more turf there. People call it the Trump states that the Democrats have to defend. So, there's a lot of toss-up races. It's not clear. There is a pathway for the Democrats to take the Senate, just as there's a pathway for the Republicans to hold the House. But most likely, the Republicans pick up 2 or 3 seats. So what I think that means for legislation, it's going to be very difficult to accomplish bipartisan legislation in this acrimonious atmosphere, and that puts a lot of pressure back on the agency to work on some of these things we've already been working on. So Mar mentioned the regulatory reforms that could happen on the Stark Law. We can certainly push forward on that. We can do more on site neutrality. There's just all kinds of opportunities for us that we don't stop just because there's gridlock within Congress. There's policy goals and achievements that can be made at the administrative level.
Fantastic. I just want to tell all of the LUGPA members, if you go to Washington, D.C., both Tracy and John are always, please call them. They want to help you visit with your senator or your congressman, no matter what committees they're on, and get you in front of them. They're amazing in having that ability to do that. And I know Mara and the Health Policy Committee under Deepak's leadership, we're doing many more blasts to the membership through the Communications Committee and directly through Health Policy. And we're really trying to keep everybody up to date as much as possible. So much is happening. And so any feedback that you have, or if you're not getting the communication, let Celeste know if you're not getting the emails. Any final thoughts?
I would just say that, so in my previous life, many decades ago, I worked as a lobbyist, and I did some health policy, and what I've seen at the policy access, the depth of analysis, the sophistication of the materials, and frankly, the integration between the political affairs and health policy, really, I don't think as just a member of LUGPA, I had any appreciation for the level of work that was going on. And I think that really speaks to the decade-long effort that it's taken to build relationships, to generate a team of consultants and a legal team and people that really support us and really build contacts both at CMS, in Congress. It's really just been, I mean, for anybody who's interested, it's actually been a pretty tremendous opportunity. So thank you.
Super, well said. And with that, we're right on time. And I think there's some travel issues we have in front of us. So we'll exit stage left and turn the rest of the time back to you, Dr. Kirsh, for political affairs update. Thanks, guys, very much.
Thank you.
Thank you.
So I'm going to try and speak a little more briefly than I often do, which is usually not successful. And I'm going to have a guest speaker this year with me as well. But before I get started, I would just like to ask, is it refreshing to see Dr. Holton up here or what? I mean, Kapoor is great, but that was very refreshing. So I have some slides that I've used before, and I may skip through some of them. How many of you are at your first LUGPA meeting? So there are a few people that need to be indoctrinated. So one of the things that we want the members to understand is that in Washington, there is a real blended effort between what we call political affairs and health policy as reflected by this panel. And they're really just kind of shades of gray. On one extreme in health policy, you have political people such as myself or John and Tracy involved in the comment letters that are going to CMS, but the heavy lifting on data analysis and those concepts is way over on the side of health policy. And that is, you know, Kapoor's analysis along with our legal team, Howard Rubin and his associates. And then on the far other side of the extreme is the political operation that I represent. But it's not me and him, it's really, I would like to echo what Maura said, which is that it's really all hand in glove, and we're very fortunate in this organization that it's all unified and it's really very effective. What I want to talk about now a little bit is the political operation and what the Political Affairs Committee does. The Political Affairs Committee supports health policy in a way I just described, and also does some very specific political things. Legislative agenda determination. You know, the policy people will support the agenda, but we have to help determine the legislative agenda for the organization. We have to do these fly-ins that you've all heard about. How many people here have been to Washington with us? Raise your hands. Excellent, not enough. Okay, and we have to do champion development, which comes down, as you know, also to fundraising. I want to acknowledge the members of the Political Affairs Committee that are listed here, and all have worked very hard and come to Washington, D.C. multiple times over the last year. The LUGPA legislative agenda is here just because, just for a factual basis, we need to have one, and this is what we stand for. We talked about Stark reform, our efforts to pass that bill. We talked about, in the recent rule update, site of service neutrality. Those are our top two priorities. And then number three, which is emerging, as you just heard on the panel, is advocating for our ability to continue to provide pharmaceuticals, both on an in-office and what's going to be rising to the top in the coming year is this Medicare Part B issue. We continue to work on radiation therapy. You may recall that a few years ago there there was a legislative freeze. You may remember, those of you who've been around for a while, that every year, summer after summer, CMS would have a proposed rule to cut radiation therapy by 30%. We'd all have to run up to the Hill, get our senators and congressmen to write CMS and tell them not to do it. Then they wouldn't do it. And finally, they passed a law in Congress, in large part with our input, to stop that nonsense, and they directed CMS to come up with an APM around radiation therapy, which they have not done. So we continue to monitor that issue very, very closely. And I will say, with all candor, we're backing off from the USPSTF issue, with the PSA testing issue, as terms of our priorities, simply because, as has been said earlier in the meeting, a lot of that problem was solved by additional rulemaking by the task force. The bill itself, if I'm being candid, does not have a lot of traction in Congress right now, and some of us have determined that putting our money and political capital into that effort may not be as important as some of those things higher on the list anymore. So the second point, first point was the legislative agenda. The second point are these fly-ins. We really want you to come to DC. Members of Congress don't want to only hear from Tracy and John and their staffs. And frankly, they don't even only want to hear from me. They want to hear from rank and file people. And I can't tell you how much they respect the fact that doctors would take a time away from their practice and come to Washington to talk to them about issues that relate to patient care. So it's really, really effective. We can't get it done without you. In 2018, we had 6 separate fly-ins. Each fly-in is 2 days. So, and they're in the middle of the week. So, you know, I don't want anybody to cry for me, but just imagine that you got to come in and then you got, it's 3 days out of the middle of the week. 6 times is 18 working days this year. That's what your Political Affairs Committee has done. And that doesn't include other trips to DC for emergency issues and other things that come up. So people are really working hard for you. Come to one and just help us out. It's really helpful. I wanted to invite, make this more participatory. I would like to invite 2 people. Howard, you're Ash. So we got a little typo there. We got Dr. Howard Williams and Dr. Scott Sellinger, who would like to come up. I'd like them to come up and report on their experience in Washington with us. Gentlemen. Actually, the truth of the matter, the reason the slide is wrong is Ash is a young doctor. His picture is not here. His name is from Florida. And he wasn't on the Political Affairs Committee. He came to a fly-in. He became so passionate that he came, and he's early in practice, and he came to the rest of them. And so we wanted you to hear from him, but he had a family emergency. Howard, Scott, why don't you come up too so we can save time? Just both of you, don't take too much time away from me. Just make brief. Keep it brief. Howard?
Thank you, Gary. So my fly-in experience was really a very eye-opening experience. First time, I kind of used that to play dumb in front of the senators and House representatives. And I always knew that we had political representation in Washington, but you really never realize the importance of it until you do it. And I found it to be a very, very eye-opening experience. And I really want to thank Deke and Gary. They take out a tremendous amount of time from the practice, and we all should give them a round of applause for these commitments, because it's a lot of time, and when you're there, you're really busy. I mean, they run you around from Senate. I don't know what the hell building I was in, but we're going through tunnels, and it's minute by minute of all these arrangements that they set up. So the whole experience really reminded me what I already knew, which was of all the organizations that myself and people like you belong to, it's really LUGPA that's the most important organization. And it's not only at this time, but it's really in the future. And they do a fantastic job for us. And I found it to be very motivating and beneficial. And I really think you all should seize the opportunity to participate. So thanks, Gary.
So I've been on the Political Affairs Committee for 3 or 4 years and have made numerous trips to DC with Gary and the team. And I will say, the one that you don't want to go to is probably July because it's always so hot, and we're all just perspiring like crazy running in and out of cabs. But most of the rest of the time, it's actually very pleasant to be there. But my message to all of you is not to be afraid to participate, not to be afraid to go to DC, and not to be intimidated. You know, we're urologists, we're urologic administrators, and we always know more than they know about what we do every day. And so when you're asked to describe what it's like to be a urologist in an independent practice or an administrator in an independent practice, you're the one that has the knowledge base, and not to be intimidated by that or to be scared to speak up. And as for the health policy agenda, you've got people like Gary and Deke and John and Tracy, and they'll prep you. You'll have little meetings before you go into the meetings with our senators and representatives, and they'll prep you. And if Deke is there, he'll do most of the talking anyway. But occasionally we'll get a few words in edgewise when it comes to health policy. It's especially powerful for us to attend these fundraising events for our congressmen. And if your group is selected to support a representative or senator from your district or from your state, I would encourage you to send someone to DC for the fly-ins. Like Gary said, you take care of their constituents, and your message that independent urology groups are doing everything to provide the highest quality care to their constituents is a very powerful message. By us being there, we make the health policy agenda very real for them, and it really brings the message home. So my experience has been tremendous on the committee, and again, I want to thank LUGPA for having that opportunity to be there and to participate in that. And so when your group is called and you have that opportunity to go, please try to send a member to visit. Thank you.
Thank you, Scott. Thank you for your participation. I want to make a special appeal also to the practice administrators. We want you to come to DC too. And we have a dearth of those coming. I mean, we get some docs, we have a dearth of everyone coming, but we get some docs, but we need more admins to come. We need you to understand the process as well so you can translate that back at home. And you guys are very articulate and you understand the business, and you'll speak very well to these issues with members of Congress and others at the agencies. So please join us more than you have in the past. When it comes to developing champions, obviously they're a critical part of our success. We have a specific strategy, and I've reviewed this many times, but there's some newcomers. Champions for us are individuals who serve a particular role in the Congress. Usually they're either in leadership or they're in one of the key committees of jurisdiction for health care, which in the Senate is only one committee called Finance, and in the House is two committees, one called Ways and Means and the other called Energy and Commerce. And then we also have a group of people in the Congress who are doctors and or affiliated professionals, even some nurses. And those healthcare people are also a focus of our efforts because we have a natural alignment with them, and they have a natural understanding of our issues. And actually in the Congress, they are sometimes looked to opine on healthcare related matters, so we want to engage them as well. How do we get a champion? We get a champion because of these 3 points. One, there's a shared philosophical alignment. You're not going to convince somebody who completely believes that we should close the in-office ancillary services exception and not ever let a doctor run an independent practice otherwise on any basis, doesn't matter what kind of donation you give them. So it's a waste of time. You have to have people who share our alignment around a competitive balance in the marketplace to employment, better, faster, cheaper, our whole LUGPA mantra of access to care and value. We have to find people who are aligned with that, and believe me, they exist on both sides of the aisle. Secondly, we have to have data, because when we're challenged, we got to support our positions with data. It's not good enough to come in and make everybody feel good or give a donation. And again, on the spectrum of what we do, as I said earlier, on the data side, that's where we get far over to the health policy analysis side, and we allow those folks to provide the data to the political arm to communicate that data to policymakers. And then, of course, we do need the money, and everybody's sick of hearing about the money, but we do need the money. So what do we do when we go to DC with these fly-ins? We usually sit down with a member of Congress, the House or the Senate. We have an intimate meeting with them, 6 or 7 of us, one of them, for an hour over breakfast, lunch, dinner. And we come in for these mini fly-ins. As one of the speakers said, I don't remember if it was Scott or Howard, we really do run you around because we'll do breakfast, lunch, dinner one day, then breakfast, lunch the next day with a senator or a member of Congress. And in between all of those events, there's all these other smaller visits around Capitol Hill. These are not inexpensive. They cost $15,000 to $30,000 or so each. Fortunately, you all have been generous enough in supporting our efforts that we're able to do a number of those over the last year, as I will show you. As I indicated earlier, we support the key committees, and these are bipartisan. But what I'm emphasizing to you is we do need the money. You're going to hear an appeal for money in a minute. We can't do it without the money. It's more than money, though. It's the whole system working together that you've seen up here today, as I've repeated many times. However, without the money, the machine does not have any oil. The machine has no oil without the political contributions. That's just how it works. Now, when it comes to our LUGPA contributions, we get these questions all the time. I'll run through it quickly. No, your group cannot pay with their corporate funds. It's illegal. I'm sorry. The funds have to come from individual urologists. We know that that's difficult. We know it's hard to raise that money. We just have to do it anyway. That's just the way it is. It doesn't matter if you have 100 checks for $50 or 2 checks for $2,700, but they have to be personal checks. And I want to say a couple quick words before I turn it over to other speakers about PACs. I get this question a lot. Does LUGPA have a PAC? What other PACs are out there? LUGPA does not have a PAC, and LUGPA does not want a PAC. And this is the reason. PACs by law can only give $5,000 in an election cycle to a member of Congress. An election cycle is 2 years for a member of the House and 6 years for a member of the Senate. If we have to build a champion out of Senator Portman or anybody else who has to raise millions of dollars to run for re-election every 6 years, it's very unlikely that we're going to get to sit down and have lunch with him and explain our issues if we can only give him $5,000 every 6 years. It just doesn't work. It's a model that does not work for us. It's a model, a PAC model is more applicable to a broad sprinkling of money around the Hill. This is not what we do. We have a very focused approach, as I said, with certain members, champion development, committees of jurisdiction. So we don't want a PAC, and that's the focus of that slide. I do want to emphasize, though, that there is PAC confusion. And by that I mean this. First of all, we're not a PAC. We don't want to be a PAC. I've already said that. Secondly, urology has a PAC called EuroPAC, nice people, good organization. And then I understand just recently, within the past week or so, the AUA, in competition with EuroPAC, which, you know, I have no comment about, but just having no comment, you ought to understand what I'm saying, is decided to make their own PAC. Well, and there's going to be confusion amongst all your colleagues now. They're going to hear, well, give money to LUGPA, give money to EuroPAC, now give money to a new AUA PAC. So I'm here to tell you today, forget the confusion. The answer is you only give the money to LUGPA. That's it, okay? That's where you give the money. If you have leftover money because you really want to be politically active, by all means, give to those PACs. But your first duty is to give the money to LUGPA. Okay, so the following groups have contributed in the last year. I can't read all their names because there isn't enough time, and if I left your group off, as happens every year, I leave this room, somebody comes up to me red in the face, my group wasn't listed, I apologize. Okay, but we have 4 slides, and those who want to, in the past I've asked everybody to stand. I'm terrified of John Henderson. I cower in front of him anymore, and I'm just afraid very much that we would run over time if I had all these groups stand. But I'd like a collective round of applause for all the groups that have donated. We have a tradition of rewarding people who've made extraordinary efforts towards our political work. Last year, we gave an award to John Adams from Conrad Pearson, Carla Blue from Colorado, Tim Langford from Arkansas, and Brian Melhoff from Oregon. This is just a reminder that they did great work, but it's like that speaker we had. You know, that 24-hour clock. That was yesterday, okay? So, you know, you don't get much more credit for what you did yesterday, okay? But still, we thank you for last year, but we'd like to see you up here again next year doing something else great. But let's talk about who we're going to give awards to this year. We have 3 physicians that we want to particularly honor this year from political affairs, 3 of them, and I'm going to list them in no particular order. The first is Howard Williams, who was just up here. Howard, will you please come up? Make it quick. I'm worried about Henderson. Dr. Williams did an amazing thing with his group in Syracuse. How many doctors you have? 26 physicians. And he led a campaign to increase their individual donation to LUG Political Affairs from $500 to $1,500 per physician this year. And he fulfilled that pledge 100%. And this is the largest year-on-year increase we've ever seen from any group. Thank you very much, Howard. And you get a trophy. Thank you so much. The next person who is not here to receive it, but I think somebody from Mitch's group is here, is MIU in Michigan, Dr. Hollander. We had a particular problem, and we had a little bit of a crisis where we had funding for a senator lined up, and the funding fell through. And I called Mitch, and he stepped up and corralled his group and delivered 100% of the $20,000 that we needed for that event on short order. And for that, we are, for an event, and we can never, ever come up short for a member of Congress. We have a reputation. We don't ever come up short. So we want to thank, and is Nicole coming up? No, thank you. Nicole is the CEO or practice administrator, or whatever you want to call it. Please come up from MIU so they can take a photo. And thank you so much for all of your efforts.
Thank you.
Thank you.
Thank you for encouraging us.
And the last person who was going to get an award I introduced earlier, he couldn't be here due to a personal emergency, was Ash, who is, I think he's from Scott's group. And despite not being a member of the Political Affairs Committee at the time, he came to a fly-in, and then he came to every other fly-in basically the rest of the year. So Ash will get an award mailed to him. And Scott, thank you for sending him to us. Let's give him a round of applause. Well, I only have about 2 slides left, and in the 9 or 10 minutes we have left, I'm going to turn it over to another speaker. And I want to talk about how we're doing with LUGPA Political Affairs. I have 2 slides. This one is a little less important than the next one, but they all have data. This slide will tell you what we did in the last year. In the last year, we deployed $591,000 as an association. Of the money pledged, 95% was collected. That sounds good, but if you're Gary and you have an event in 3 days and you owe the guy 15 grand and you only have 10, that 5% that we didn't collect is very troublesome to me, and we don't like that. So please make a pledge, but please fulfill it. 42% of our groups contributed. That's great, but it should be higher. 36% of our physicians contribute. That's great, but should be higher. And in the past year, we did 29 unique fundraising events, averaging $20,000, bipartisan, bicameral. I think if the House flips, we're going to have to focus a little more on Democrats next year. And I don't take any position as to whether you should like one party more than the other, but I want to remind folks that we can't allow our personal politics to get into this. We have to support what's good for independent urology and independent medicine. And if we have to ask for more from one party or another based on the political wins, that's our job. You still need to help us. This is the last slide I'm going to give today. And when you talk about an election cycle, I said there were 6 years for senators. That's true. But generally, we refer to election cycles in this business as a 2-year cycle. So if you go online and look at, how did a PAC do? It's all based on a 2-year cycle, 2016 to 2018. Well, next Tuesday will be the end of this political cycle with the election. And so data as of late October is posted here on this and the next slide. So in the last cycle, 15-16, LUGPA did $544,000 over 2 years to Congress. In this past cycle just ending, we did $1 million. That is a very phenomenal achievement, but we cannot stop there. This is 54 events, bipartisan, bicameral. You all deserve a round of applause. Thank you so much for your support. But even more important, and this really is my last slide, is how we are doing in the House of Medicine. And this is something that this organization should be unbelievably proud of. It's hard to even believe that if you look at the top 10 medical PACs this election cycle, the American Academy of Orthopedic Surgeons, the American Society of Anesthesiologists, these people have tens of thousands of members. Then you have the American Dental Association. How many members does the American Dental Association have? And then you've got the emergency physicians. Well, LUGPA's donations are the equivalent of a top 5 medical PAC. And this, out of 2,000 or 2,500 urologists, is a phenomenal achievement and does not go unnoticed in Washington, D.C. So we must keep it up. We're going to have challenges. When the House flips, if it flips, we're going to have the in-office under assault again. We're going to have these Part B problems. Please don't let up, because we're here to protect you. So with that, I'm going to turn it over. Usually I do the appeal. A lot of people are quite familiar with that, but this year we've got a new face. I want to introduce Dr. Adams. John?
Well, good afternoon. Gary toned it down quite a bit from usual. I got drafted onto this committee about a year ago. I decided my group was sponsoring one of the fundraisers, and Gary said, you got to come for a fly-in, and I did it and felt like I did what I was supposed to. He said, by the way, you're on the committee now. Oh, okay. We'll explain this in a minute. So he said, well, then this year you get to do this appeal. Okay, I can handle that. Because it was an incredible learning experience, incredible exposure. I didn't know what went on with LUGPA in Washington. And it's given me a great appreciation for a lot of hard work that's being done on behalf of all the members by a select few. I mean, LUGPA has had this incredible growth since its inception. We have excellent credibility within our own community. We're now an essential resource for independent urology. And LUGPA is by far the greatest advocate for independent urology practice in D.C. We have a high level of recognition in Washington. People know who LUGPA is in the Congress and federal regulatory agencies. And as I like to say, we've got boots on the ground on the D.C. battlefield. We've got our lobbyists that are there all the time. We represent on both sides of the aisle. We've got Tracy Spicer and John McManus's groups, which are excellent. We've got Deke and Gary that are up there all the time, and we have the fly-ins. As he mentioned earlier, we've got several events a year. Each lasts for 2 days. These are meetings or fundraisers arranged with different senators and representatives that are on key committees. This isn't just any representative or any senator. It's someone that has a say-so in the regulation of our business. We also have meetings with the congressional staff. Another thing that surprised me, most of Washington is not run by the members of Congress. It's run by 25 to 35-year-olds that run their individual offices. They're the ones that put information in front of our congressmen. They're the ones that put things on the agenda. So spending time with the staff is really important. It's also important that we have involvement of LUGPA members that are constituents of these members that are being given fundraisers. It's nothing like seeing a face from home, somebody that has familiarity, knows the home territory. You're speaking to your representative, to your senator. So it's real important to take the time out of your practice and come to Washington. We have breakfast, lunch, dinners, receptions, staff meetings. Now, sometimes these meetings are with unsavory characters. We know that there's a lot of different types up in the swamp, and it really is a swamp. So sometimes you have to pinch your nose to avoid the smell, but you need to go. Now, Gary talked about our data from 2018. There's a real problem with that data. To me, it's kind of poor. Only 36% of LUGPA members, representing 42% of the groups, donated to political advocacy. So that means look to your left, look to your right. One of the three of you is the only one donating. And that's really poor. I mean, this is representing our future. This is representing our practice. Our whole future is wound up in our representation because the laws are being made that can change practice in an instant. Look what's happened in the last 24 hours. The average donation made per donating member was a paltry $769. Now, we know that we make a pretty good living, and $769 is not a lot of money to spend on your future and preserve your business. And as Gary mentioned, it was also concerning 5% of pledges were not honored. You can't tell the senator, sorry, Senator, maybe we do this another week because the money didn't come in today. So it's real important we make a pledge, we honor it. So what do I consider a reasonable expectation? Well, we have, at the last count, 2,155 members. It's gone up since then. But $1,000 a member is not an unreal expectation to preserve your business, preserve your profession. That would give us more than $2 million of annual support and more than $4 million of support per election cycle. We could really have an impact. You think they know LUGPA now? Wait till we have that kind of support. We have to have this support to have access to Congress. To have a voice, you got to have access. And sorry, good, bad, or indifferent, it takes money to have access. And LUGPA is the only representative of independent urology in Washington. So in summary, we need to maintain access to these key members of Congress. We've got a lot of relationships established over the last several years. We've got to continue to educate lawmakers with a clear and concise message to protect our patients and our business. We've got to maintain lobbyists on both sides of the aisle to promote our message. It doesn't matter which one's in power. It doesn't matter who wins an election, you got to go to work tomorrow. And our businesses have to be protected. And it's real important to have urologists present the message to the lawmakers. We've got to raise money to do all of this. So what's our big need? Dollars. That's the basis of everything we need to make this machine work. Now, this is kind of funny. You say, what in the world's he got up there? Well, I'm from down south. You probably can't tell that. This is chicken bucket. Well, when we're down south and we're raising money, it doesn't matter if it's a big social event, church event, you pass the chicken bucket up and down. And you say, okay, we want you to put your coin, we want you to put your cash, we want to put your keys to your car, the deed to your house, put it in the bucket because we got to raise money. We're locking the back doors until we get all the money filled up in all these buckets. We're not asking for all that. We're just asking for a pledge card. A lot of people are reluctant to say, well, I think one of my partners, he's filling out his card. No, everybody fill out a card. We're not going to double dip. We're not going to have two different cards. You got to fill them both. But we will take the highest bidder. If one of your partners bids more than you do, we're going to take his bid. So it's real important. We've got to continue the advocacy. We've got a great start, and we can do so much more, but we need dollars and we need doctors to participate. So when Gary calls and said, hey, listen, we got to fly in. We're doing an event for your representative, your senator. We'd really like to have you there. Come. It'll be an eye-opening experience and plus help our cause. Thanks.